There's a pharmacology for immunosuppressants, okay? So essentially for the USMLE, the immunosuppressants will work on active lymphocytes, okay? Not your neutrophils, not your basophils, eosinophils, your lymphocytes. And they're going to prevent their activation and their proliferation. They're used in acute transplant rejection, suppressing cellular immunity, and used as prophylaxis. But you have, of course, chronic use can lead to opportunistic infections. We can have malignancies. I really want to bring our attention to this diagram over here, specifically calcineurin. Okay, calcineurin, guys, is basically a protein, phosphatase, a calcium and a calmodulin, and they are going to be dependent serine thymine phosphatase, and they play a crucial role in T cell activation and proliferation. So basically, they are going to be activation, proliferation, and what is the main function of calcineurin? Basically, we have an NFAT, which is nuclear factor activator transcriptor, which is nuclear factor activator, nuclear factor of activated T cells. Okay, so nuclear factor of activated T cells, and basically these are also family of transcription factors essential for T cell activation. So essentially, calcineurin and nuclear factor activator of activated T cells. They basically this is phosphorylated, gets dephosphorylated, and then this allows for transcription, and this nuclear factor of activated T cells promotes the expression of cytokine genes like interleukin 2, which is essential for T cell activation and immune response. So that's basically calcineurin. And let's come over here and speak about the drugs now. So the reason I spend so much time on calcineurin is because cyclosporin and tacrolimus both inhibit it. Okay, so cyclosporin is basically a calcineurin inhibitor, and it binds to cyclophilin. Cyclo refers to cyclosporin, and philin means love. So cyclophilin is a ubiquitous, it's a common. It basically are going to be highly conserved proteins in all organisms, including the prokaryotes and eukaryotes, and they basically are going to be working to activate nuclear factor of activated T cells. Of course, if you inhibit calcineurin, if you inhibit nuclear factor of activated T cells, you decrease amount interleukin 2 and transcription. Same with tacrolimus. Tacrolimus, however, is also calcineurin, but binds FK506. FK, the reason why we call it FK was basically they found this in the lab. It was Fukushika, Kagawa, so somewhere in Japan. 506 was kind of like the code. So it's the FK binding protein. It doesn't inhibit, it binds to FK506. And basically, again, the same effect, which is a T cell activation, and it prevents interleukin 2 transcription. Then I want to come to cerumelis or ramamycin. So cerumelis ramamycin is mTOR. So mTOR stands for mammalian transcriptor of ripamycin. So ripamycin, which is our drug, or cerumelis, same thing. Target of ripamycin is basically a protein kinase, which plays a central role in many cellular processes, including cell growth, proliferation, and survival. So we can see over here interleukin 2 receptor, which is going to be over here. So we can see mTOR, which is basically mammalian target of ribomycin, is a protein kinase really for cell proliferation. It proliferates genes. So transcription basically means DNA into transcription into RNA, which then makes proteins. So it inhibits. It's an mTOR inhibitor essentially. Okay, inhibits mTOR. It also binds to FK506 and blocks T cell activation over here and prevents interleukin 2. Blocks T cell interaction, B cell differentiation by preventing exposure to interleukin 2. We have over here basal CMAB. It's a molecular antibody which blocks interleukin 2, but it won't be asked on USMLE. It's not that common. I want you guys to know these three drugs, and I want to speak about the side effects as well. So cyclosporin, it's a calcineurin inhibitor, cyclophilin, and fats, so nuclear factor activated T cells, it activates that and inhibits that. So you want to know three main risk factors over here. So the three main risk factors is going to be, it's going to be essentially for high blood pressure, it's going to be for like virilization, so high on here, and kidney toxicity. So we don't use this essentially for kidney transplant. We would use this just as a normal immunosuppressant. So, for example, rheumatoid arthritis. It involves it's an inflammatory condition. Psoriasis arthritis. That's also an inflammatory condition. The next thing is going to be cerumelis. It's going to be tacrolimus. So tacrolimus is also calcineurin inhibitor, but it has some other FK506 binding. It's a side effect. I want you guys to learn three over here. Okay, neurotoxicity, glomerulonephritis, and diabetes. So it can kind of bring up the sugar. So these three I want you to know. Cerumelis is FK binding. It binds to FK binding, inhibits mTOR. Main target of ripamycin, and then we have cerumelis or ripamycin. I want you guys to know that it is used in it is fine in kidney. Okay, you can have it. You can maybe get some high lipids. That's the only side effect I want you to do, but you can use that for kidney transplants. So sirolimus or rifamycin, we use this for kidney transplant. We have another drug called azithromycin, basically anti-metabolite or 6-mercaptopurine, inhibits lymphocyte proliferation by blocking nucleotide synthesis. These are also used for many, but they're not very commonly tested. Azithromycin and metabolic 6-mercaptopurine improves this. You can know that it inhibits PRP aminotransferase. They mentioned over here. So with this, it's pyrophosphorybosyl transferase, cellular metabolism, particularly in biosynthesis of purines, pyrimidines, and building blocks of DNA, RNA. But there is some link with it with xanthine oxidase. I'm not too familiar with the pharmacology. I need to brush up on that myself. I believe it's a purine analog. So because it's a purine analog, it cannot be used with xanthine. It cannot be used alpineol because that too is a purine. It is a purine analog. I'm not too sure. I need to rise on my that part of MSK pharmacology. The next drug which I do want to speak about is mycophenolate. Again, IMP dehydrogenase prevents purine synthesis in BNT cells. Nothing too much I want you guys to learn. It won't show up on your exam. Glucocorticoids, very important, inhibits NF-kappa beta. So one thing the FA does not mention is that it basically NF-kappa beta, it goes to the nucleus and it does this. It converts DNA into RNA and makes proteins for inflammation. We have these things called, so NF means nuclear factor kappa beta. We have IF kappa beta, IF inhibitor of I kappa beta, inhibitor of kappa beta. Okay, so just the inhibitor. It prevents this to occur. Okay, so essentially this would get phosphorylated, and then you would go into the nucleus, convert DNA into RNA, and you would do inflammation. So glucocorticoids want to inhibit this. Okay, it wants to inhibit this. How does it do it? It gets I kappa beta and binds to NF kappa beta and prevents it for it to go to nucleus, DNA, RNA synthesis. So that's essentially what you guys want to know. So it suppresses B and T cell function, decreases transcription of cytokines, induces T cell apoptosis, many autoimmune inflammatory disorders, adrenal insufficiency, asthma, CLL, non-Hodgkin lymphoma. I want to recap over here, guys. Cyclosporin is a calcineurin inhibitor. It's a cyclophilin. It binds to calcineurin, which it decreases T cell activation by inhibiting IL-2. Side effects: hypertension, virilization, and kidney problems. So therefore, uses in autoinflammatory diseases. The next one, tacrolimus, is a calcineurin inhibitor, which is an FK binding protein. It has the same function, more or less. Side effects: neurotoxicity, glomerulonephritis, and diabetes. Used for organ transplant, like lung transplant. Okay, next is sirolimus or rifamycin. This one over here it's an mTOR inhibitor, not cycloneurin, mTOR inhibitor, but the same effect. It blocks T cell proliferation. It is going to be utilized for kidney transplant. I'm not going to recap those. I'm going to come to glucocorticoids. It inhibits NF-kappa beta by having I-kappa beta. Blocks T cell proliferation, T cell apoptosis. It's used for autoimmune diseases, inflammatory diseases, adrenal insufficiency, asthma, CLL, non-Hodgkin lymphoma. So guys, that was all of your immunosuppressants for the USMLE. Hopefully you found this video useful and hope to see you guys next time.